Bonjour, bonjour, hello. I'm delighted to be with you today. CanCOVID is a national organization committed to supporting an evidence-informed approach to the COVID pandemic and facilitating science policy knowledge mobilization across the territories known as Canada. I am located in Ottawa, on land that has never been surrendered, ceded, or covered by treaty, and whose traditional keepers are the Anishinaabe Algonquin people. As we enter our discussions together, let us acknowledge the lands on which each of us live and work and the traditional keepers of these lands. Let's keep in mind that the science to policy relationship has often harmed Indigenous peoples in these territories while ignoring and discounting their knowledges, communities, and lands. Let us commit to promoting scholarship and dialogue that cultivates respect and healing. I am just thrilled to be presenting this amazing panel of prestigious scholars who have been working so hard on approaching COVID-related issues in long-term care. We have with us Andrea Baumann, Associate Vice President, Global Health at McMaster University, who is also a fellow of the Canadian Academy of Health Sciences. We have Dr. Raisa Deber, professor at University of Toronto, a member of the Royal Society, and a fellow of the Canadian Academy of Health Sciences, and Mary Crea-Arsenio, senior research analyst, Global Health Office at McMaster University. We are just delighted and can't wait to hear what you have to say. I'll pass it over to the team.
Thank you very much. This is based on some work that was done for a special issue, done on a grant that was funded by the Canadian Institute of Health Research, and the results have been published in a special issue of Healthcare Policy. On the next slide, I'm going to try to put this into a little bit of perspective. And one of the approaches that you take on this is accountability. And what accountability is can be defined as having to be answerable to somebody for meeting defined objectives. And it's complex because there's financial elements, there can be performance elements, there can be political democratic dimensions, and there's a lot of different elements of accountability. And the ones that we were focusing on, and this comes from an earlier paper that we've done on accountability, also in healthcare policy, accountability for what, by whom, to whom, and how, including what the consequences are of not meeting the targets. On the next slide, we talk a little bit about the for what. And the for what can depend on a lot of things, including what's called the production characteristics, which includes things like how easy is it to measure and how many other contestability, which is how many others could be doing similar things. So are you competing, or are you on your own? Complexity, which is how intertwined are you with others, or are you again on your own? So some of the sorts of things that we could be talking about under COVID and long-term care is the quality of care you're talking about, the safety, the staffing. The next slide, by whom, what was government responsible? How about the long-term care homes? How about the staff within the long-term care homes? How about the patients and their families? What about the general public? The next slide, to whom? Are you accountable to the government? Are you accountable to the long-term care homes, which a lot of say the staff might be, to the professional associations, if you're a licensed health professional, to the residents and their families, to accreditation bodies? On the next slide, how, and one of the tools that you can look at is what's called policy instruments, which include things like information and education. Are you reporting things to the public? The regulation, and there can be various accountability agreements. Financing and financial incentives, you get paid for meeting standards. Public ownership, which is we take you over. And who's actually going to be accountable if you fail? So I'm going to hand this over now to the rest of the team, who will be talking about some of the specific findings that we have. Next slide.
Sorry about that. Sorry. Thanks, Raisa. I will begin and then I will pass it over to Andrea. As Raisa mentioned, this work was a collection of papers that were published in Healthcare Policy, a special issue in Longwoods. The papers were focused on issues and challenges that long-term care faced during COVID and some analyses pre-COVID and post-COVID. Next slide. Great. So for today, we're going to focus on a collection of these studies. So not all 9, but a series of studies that looked at the key issues that we identified throughout the period of time of analysis. These issues are things that have emerged in a collection of writings, previously, and they were further exacerbated as COVID, as we know, COVID approached and had some devastating effects on the long-term care sector. We also want to present, though, some findings from casework that we did that looked at what some homes did well. So we wanted to analyze what happened in those homes and present some findings on some solutions or some suggestions for where there could be improvements. Next slide. So to begin, I just wanted to say we did use multiple methods in our analyses, and these methods included document analysis, where we looked at inspection reports, we analyzed gray and published literature, we looked at government websites, we examined the legislation in long-term care, which has recently changed, that was important, and we also looked at newspaper reports over a 2-year period to really understand the extent and the comprehensive nature of the issues of abuse, neglect, mortality, and social isolation in long-term care. We coupled that with a quantitative analysis. It was a regression analysis that was conducted by our lead author, Nuri Akhtar-Dinesh, where we looked at the association between clinical indicators of neglect and mortality among long-term care residents in the province of Ontario. And I did want to say, the data we're presenting today are mainly from the studies in Ontario, but the full publications will be posted online, and you will have a link to that on the chat where you can access all the studies that were conducted in the special issue. Next slide. So in Ontario, the definitions of abuse and neglect come and are found in legislation. And so these are the ones posted here. Legislation is used by the inspection process in order to ensure homes are compliant, that homes are protecting residents. They have a duty to protect them from harm, which includes things like abuse and neglect. For our purposes, we wanted to analyze the incidence and the extent of abuse and neglect in long-term care homes. And the data we used for that were the inspection reports. Reports are publicly available. So it's an open access government website that lists all inspection reports available across time and for every home that has ever had an inspection. So this is a rich data source that, as far as we know, has never really been mined in order to extract information about key issues that have been reported for a long time in long-term care. These are not new issues. And so we use that database, that administrative database, to extract information and then focus in on these key issues. Next slide. So I'm going to present a little bit of the findings here. And again, this is sort of high level because of the interest of time. As you can see, cases of abuse and neglect in Ontario do vary over time, but they're sort of consistently sitting around that 10 to 13% mark based on the reports that we analyzed. What we did is we looked at reports over a 3-year period, so beginning pre-COVID, 2019, and then in the first 2 years of the pandemic. And what we found is that the number of reports posted do vary, but for different reasons. And so, you know, we don't think that this trend of decreasing inspections is due to any real change over time, but instead due to some external factors that affect the number of inspections that get conducted each year. In Ontario, in 2018, they removed what used to be called the resident required inspection. So annual comprehensive inspections that were done every year on every home, that was removed. We know that during the COVID, the first year of the COVID, they weren't doing any inspections in person because of the restriction on visitors into long-term care. And so there are a lot of factors that sort of come into play when interpreting the data. What we did know was each year, all 626 homes in the province did have at least one inspection. They weren't all related to abuse and neglect. However, 50% of those homes did have a case of abuse or neglect. And even more concerning was that a third of the homes had repeated cases of abuse and neglect identified in the inspection reports. In our study, we described that there is some underreporting. We believe some underreporting. The categories that we selected to analyze were related to the two legislative protocols linked to abuse and neglect, but there are many other protocols that when we were analyzing the data, happened to notice that there were some other cases that could be identified as abuse and neglect, but they happen to not be classified by the inspector in that way. So we were quite pure in our analysis to extract only those cases that were inspector identified and linked to the legislation as abuse or neglect. Next slide. We also took an analysis of the reports and we extracted some quotes to give examples of what these cases look like. So I'm going to pause. I'm going to allow you to read them. The first slide will be about abuse. The second will be about neglect. Just take a moment. Okay, can we go to the next slide? Here are the cases of neglect. Okay, next slide. So as those quotes demonstrate, there are some real key issues that are occurring in long-term care that are in the sector. Hundreds of newspaper reports verified these stories that we extracted from the inspection reports. And so through the triangulation of all these data sources, we were able to identify, we believe quite comprehensively, that there are cases that need to be addressed, that there are issues in the long-term care sector that have not yet been addressed, and that there needs to be more done, which we'll talk about in a little bit. So the last paper that looked at neglect was led by Dr. Akhtar Dinesh, as mentioned, and it looked at clinical indicators of neglect. We created a neglect index, and then we use that index to look at the association between residents who exhibited clinical indicators of neglect and their mortality 1 year before COVID and then also during the pandemic. And we did see a stark increase in the odds of mortality, the odds of death during COVID, but also pre-COVID in those residents who exhibited signs of neglect. Now, the signs of neglect that we included, the clinical indicators, were things like urinary tract infections, dehydration, and falls. And we believe, and literature has shown over time, that these are all areas that are preventable. And so this excess mortality is something that could be alleviated. It could be dealt with. It doesn't need to get to the point of resulting in mortality. So next slide. Okay, so another concept, another issue that we wanted to examine, which is another paper that is published in the special issue, was related to social isolation and the impact of social isolation due to the visitor restrictions. So we wanted to take a further look into what happened, how did it happen, and why did it happen? Next slide. Social isolation is important. It is also identified under legislation as a form of emotional abuse. And although it may be more difficult to measure, we did see through the pandemic that there were clear signs that residents were socially isolated and that those had negative consequences for their health and well-being. Next slide. So this is just a snapshot of time, the timeline of the visitor restrictions. We used ministry directives and we analyzed over the first 9 months of the pandemic what the directives indicated related to visitor restrictions. And there have been lots of studies over time that have shown this as well, that the impact. So what we found was that in March 2020, when the pandemic began, they had a full lockdown, which again, we all know, we've seen the impact of that. We've seen the newspaper reports, we've heard what's happened. But I think what is less known is that after about a 3-month period, they did begin to allow visitors to come in, mostly outdoors. But then after that point, the number of homes that continued into lockdown was still quite high. So although the ministry restrictions were lifted, the way that homes interpreted, implemented, and managed that varied. And it varied according to geographic location, but it also varied, based on the individual homes, the home level management during the outbreaks. Next slide. So what we know for sure is that residents were locked into their rooms were put into their rooms and isolated for up to 90 days at the beginning of the pandemic. There were no visitors allowed. There were no family members allowed, limited staff, no recreation, no social services. Residents could not leave the home freely and openly. And there was also limited direct care, again, to reduce the spread of the virus. Next slide. So the media reports, as I mentioned, we analyzed 3 national newspapers in Canada, and we looked at, over a 2-year period, how many articles were written about these restrictions and the impact on long-term care residents. And these are just a few of the examples that were extracted from those newspaper reports. Again, I'll give you a moment to read them. Okay, next slide, Kara. So what those reports showed was really the negative impacts of social isolation, where residents describe, or family members describe, how their loved ones became depressed, how there was cognitive decline, how some became immobile, weren't able to move around as freely, an overall loss of function and strength. All these things coming out of something that we understand had to balance between the spread of infection, but also the care and protection of residents in long-term care homes. Social isolation is an old concept, dates way back to the early psychology studies by Bowlby, who identified that if people aren't touched, if they're not exposed to others. If there's no interactions, then there are negative implications on the health and well-being of those individuals. More recently, prison studies have shown that, placing prisoners in isolation and solitary confinement has extreme negative impacts. So really the question for us became, why was this happening for our long-term care residents, and what could have been done to mitigate some of the challenges that homes were facing related to the spread of the virus. Now, having said all that, you presented sort of this grim picture of the abuse, neglect, isolation, excess mortality, all the challenges that have been faced in long-term care over the past couple of years. But we do want to sort of present some of the data we found on homes that did well, what they did that supported the management during the crisis, and provide some recommendations. So I'm going to pass things over to Andrea now, who will present on those findings and end off with some concluding remarks. Andrea?
Thank you, Mary.
Next slide. Yeah,
please.
sorry.
So, as Mary said, the large team that studied this, we wanted to also during the pandemic look at what worked well. And again, our focus was both in Ontario and Quebec, and the Quebec article by Dr. Lavoie Tremblay and the team are in the special issue. We're going to emphasize the findings in the Ontario study. I want to also say that this is really building on work from excellent researchers all across Canada who've been involved in creating standards, researchers such as Easterbrook, Armstrong, Dr. Sinha from Mount Sinai, and many others who have devoted many hours, exquisite writings on either what long-term care should look like, care of the vulnerable, care of the elderly. So, and we really built on many documents, including the Royal Commission, Provincial Commission, an inquest. This sector has probably more writings on the issues than equivalent sectors of the size. In Ontario, there's over 500 homes, and some of we can't paint all homes with the same brush. However, the data on abuse and neglect, social isolation is very dramatic. And it demonstrates that perhaps one might say that some homes are still in trouble. And we'll discuss that at the end of the discussion. We only picked a random sample of homes that really remain COVID-free. And we looked at private, public, different types of administration of homes as well, just to get a snapshot. And I want to emphasize this is only the beginning of this research. We continue to look at what works and what doesn't work. And I'll just present a little bit of our findings and really our thoughts today. But as I said, when you're looking at exemplar homes or quality of care, it really is a systems issue, and it's not a case of just repairing one little area. Next slide, please. When we chose these homes, and the sample was small, it was small. As I said, we went across the different types of ownerships, etc. But within the homes, we interviewed the executive director, we interviewed the director of nursing, we interviewed registered practical nurses, we interviewed personal support workers, and we interviewed, in one case, there was a full-time social worker. We interviewed that person. We interviewed dietary representatives and housekeeping representatives, just to get an idea of, having identified them as a home being COVID-free, what had they done? And how were they dealing with these complex issues? that the pandemic brought upon them. And in analyzing the results of the interviews, one thing that was clear, these homes were preemptive. They identified an issue in the January pre-pandemic. Pandemic was March, began before March, but these homes saw trends in the literature and newspapers as early as December. And they began to anticipate what they would need, an early detection. They brought in equipment in January. They brought in the PPE in January. One home brought in the Red Cross in very beginning of March to do an assessment. Since we interviewed many employees of each home, we could see very much a transdisciplinary approach to teamwork, that the leaders in the home pulled the team together with clear and consistent communication. And right from the beginning, it didn't take them time to create a communication plan. And that included communication with families as well. The homes also had very effective strategic partnerships and resources. One particular home is a municipal home, works very closely with their municipal council, kept the council very informed, asked for further resources, asked for help and support. Another home, again, fortunately, was attached to an acute care hospital. And the benefit of that, of course, is they were able to have access to their whole infectious disease department, which was actually quite large because it's a large hospital. So these homes, again, had additional resources immediately starting in March when the pandemic occurred. Next slide, please. Again, they really, in the talking to the different members in each home, they had a very close relationship with community, and some of them had a history of very strong volunteer groups. In one particular home, we put this donation in because as you know, the residents, Mary talked about how restricted they were. Sometimes they could go outside. They could only maybe go outside alone. They couldn't go outside in groups. There was a lot of directives. But one home actually had a whole walkway paved and used the local community to make it a very pleasant, tree-lined, flowers, where they could go during the period of the pandemic. Another one, again, same home actually, had a van donated and had it parked out with it open so that a couple of the gentlemen in the home who really were mechanical and liked to fiddle with motors were able to go out alone and fiddle with motors. So these are an example, again, of trying to look at very unique strategies to provide people social interaction and some meaning. Same home had a chicken coop built, again, with chickens and laying eggs, and again, trying to normalize situation. This was a home that actually is in a rural urban environment. So people in the home, some of them, again, had a more rural farming background. So again, these are just small snapshots and only a few snapshots. Again, also the issue of staffing, which we know in the newspapers became the highlight. There was a staffing report early in the pandemic tabled by the Ontario government. Staffing was an issue, and it was a horrific issue. In some of the homes ended up in wave 3 when all their employees got COVID, but 90% were off and they were left with no staff. These homes were able to maintain a good cadre of staff, and very few staff had COVID. One home talked about a mental health program because it was tense, it's pressured, pandemic effects are well known now. They instituted this green, yellow, red strategy where staff, if they were having a bad day, could wear a red button, you know, or wear a yellow button, and then they could talk about maybe their pressures or tensions. The homes we studied had a good balance between regulated and unregulated staff, which in Ontario, staffing is pretty standardized in homes, and that's probably an area which I think, you know, the staffing report emphasized and the need for more staff. Next slide, please. So we have very limited time, and you could do a whole webinar, maybe several webinars on what an ideal system, what an ideal home would look like. And we don't have the time, but we thought we would just build upon some of the reports and recommendations that have come through in the last few years. There has always been voluntary national accreditation, and it can be accessed. Their framework is quite interesting. And the research teams really feel strongly about mandatory accreditation. We know it has its issues, it has its expenses, and it's maybe not the only solution, but it certainly provides a template for excellence. We think the publishing of an annual public directory using quality indicators in each province would be very helpful to families and clients when their loved one is going to be moving to a home, or if they're fortunate enough to be able to choose what home they can place their loved one, or where the loved one would like to go. We think too, there should be a review of the leadership and administrative structure in long-term care. It's pretty standardized in this province. Again, we didn't look at every province, but you know, perhaps a study in this area would be helpful. But again, I think that the leaders within long-term care during the pandemic, it was pretty pressured, intense, and when you have an executive director and one director of nursing only for anywhere from 100 to 300 beds, that's a difficult task, and one could argue that that structure should be looked at. The other area, there was a home that we actually got in contact with, or had read about actually in England, that actually allowed essential caregivers, we call them essential caregivers here in Ontario, can't remember what they called them in England, but they allowed family members in during the entire pandemic and during outbreaks. And it was reported in the London Times that this particular home had no outbreaks, even though the director had been able to allow essential caregivers in during the entire time of the pandemic. And so we feel that sort of a trial or should be perhaps designed that would appease issues of transfer of infection, to demonstrate that you can allow caregivers in during a time of an outbreak, and it will not necessarily impact your infection rate. The national standards, which are being very large team, very accomplished individuals, and we've seen drafts, they're superb. We think they should be integrated into every province's legislative framework. And then finally, we thought increasing the proactive inspections. This is one that I guess merits further discussion. You know, quality by inspection is not exactly the way to go, but I think inspection reports can be very insightful and helpful if you're running a home. In studying the inspection reports, there's huge variation. And sometimes inspectors go in on a myriad of issues, not just one. So the reports can be very long or very short. The assessment of abuse and neglect is complicated. And one also can argue that it requires perhaps very special training. because it's a very difficult situation. The reports we looked at were quite comprehensive and very helpful with anecdotes, and each report had recommendations. So, I mean, I think it was helpful in accountability, but it's certainly not the only, again, accountability mechanism that should be used. Next slide, please. Next slide, please. So again, building on inspection reports, there are consequences that are documented in the legislation, and you can see them here. And you can see under what happens if an inspector goes in and there are issues or events are reported. We, in all the reports we looked at, yes, there were sanctions. Sometimes it was a monetary, and that monetary amount has increased in the province of Ontario to a significant amount. We don't think that actually it has much impact, especially if you see homes having more than 1 or 2 or 3 cases of abuse and neglect. It really means that system has to be looked at. One issue is, you know, if a license is suspended, it's serious. And that did happen during the pandemic. 2 or 3 homes, the military went in, one home had to be completely closed, and the people within the home were sent to 2 acute care hospitals. They had to be divided because there was so many of them. I think it was 60 or 40 going to each acute care hospital. They had to find the beds for these poor residents because basically the conditions in the home were so bad. So there was some pretty dramatic events that went on, and however we're redesigning this sector, we should design it in a way that this should never happen again. So do the current consequences work? We'd say maybe, maybe not. You don't see draconian except during a pandemic. Homes carry on, they pay the fine. Is it a home you want to send your loved one to? Well, again, that's why we think the public accountability is important. And creating a directory would help families and clients or people who are going into long-term care be able to make a very informed decision, and they should be given that decision. And the reason we feel strongly about that is because of the next slide, please. So the government initiatives have been really meeting the minimum. They have, in our province anyway, and I have to speak, our focus was our province of Ontario. They have been looking at increasing beds. We know that there's 3 or 4, maybe more long-term care homes being built as we speak, 300 beds, XYZ floors, the usual, no change. Where we do also know that in other provinces, there are some exemplar homes that have very interesting architectural designs that you know, pods of 9 people versus a pod of, 40 or 50 people on one section. So the beds are increasing. Is there any change in the architectural design? Not that we can see. The staff is also increasing. So our province has increased the number of private colleges offering personal support work courses, as well as enhancing within our community college sector, those programs. Also, there has been generous supplements offered to those who want to become a personal support worker or work in long-term care. And these are all positive directions to increase the availability of a workforce that would want to work in long-term care. The legislation in Ontario has been amended, not significantly or not significant enough in our opinion. And there's been an increase in inspection and inspectors. This around 3/4 of the way into the pandemic, there was a call to increase inspections, and I might be wrong in my timing, so I stand corrected there. But at the beginning of the pandemic, there was only telephone inspections, but that soon was, of course, I think, changed to address the issues of the pandemic. So those are the kinds of interventions our province has taken, and we would like to see sort of moving beyond the minimum. We would like to see a sort of a, next slide, please. We wanted to see more of an emphasis on a quality system. Years ago, we structured the acute care system in Ontario. I mean, depending on your perspective, more or less to the betterment, but at least it was an attempt to look at a sector and to try to look at efficiencies and effectiveness. In this particular province, we did talk about what the suggestions are in the previous slide, but a recent bill that was passed only within the last two to 3 weeks is one that has caused some concern. Due to the pressures on our acute care or complex care system, the province passed a bill that a person would have to leave perhaps a complex care bed and would have to go to a long-term care, not of their choice. So they could be moved several miles, several kilometers from where they live. The bill went through fairly quickly. It's fairly clear there. It has really, again, stripped a person of their right to choose. And our feeling in studying exemplars, you know, if you know where your loved one is going and you have adequate evidence, that would be helpful. Right now, I think the evidence is hard to find. If a person is going into a home, you know, that has had several inspections, and it's all a matter of public record, although it's difficult to find, I have to say. It took us months to extract and look across all the reports. So it's not easily accessed. And we do feel that patients and families have the right to choose where they should go based on evidence. And that's where we get, again, the recommendation of having exemplar homes within the province. And there are some, I have to emphasize that. We're not here to give a long list or to provide that type of information. But the good news is there are some homes that are doing things well. And those are the ones that should be, again, either exemplified or rewarded, or the public should certainly know about the differences in the quality of care across homes. So with that, we're going to conclude. The next slide, please. These are the Longwood's healthcare policy special issue, and the links will be provided. And they cover a broader range of topics of which we were unable to do today. Plus, we have an extensive bibliography, of course, of the many writings in long-term care we'd be willing to share with anyone who's interested. So I'm just looking at my watch, and the time is actually flying by, and I apologize, we went a little over time. So we'll open it for some questions. So I'll pass it back to Susan.
Thank you so much, Andrea. I am encouraging people, please, to put your questions in the Q&A, and I'll be keeping my eye on that. But first, let's start off with talking a little bit about who you were able to interview and who you weren't able to interview and include in the report. So we have a question about whether you were able to speak to residents and substitute decision makers, family members, and other support people in your investigations. And if you weren't able to, what effect you felt that might have on your findings?
We didn't speak to substitute decision makers. We do have some exposure to family members, though. We did speak to a random selection of family members who had a loved one in long-term care.
Thank
And
you. And
I guess, Susan, I just add, of course, their biggest concern, well, one of the many anxieties of the pandemic, but their biggest concern, or one, was definitely the social isolation. And if you look at the newspaper reports, of which there are hundreds, and we've got them, we have every single newspaper report since the pandemic started of the two major newspapers in the country, the Globe and Mail and Toronto Star. We have every one. The anxiety of family members and the anxiety of those in long-term care with the social isolation is not to be underemphasized.
so thinking about the theme that you had throughout the presentation around really moving beyond the minimum and that rebuilding trust is something that the sector really is needing to do, given the high anxiety of families and residents. Can you talk a little bit about how your research helps us move beyond the minimum? You had some recommendations that would suggest, a change in some of the accountability standards, but you also mentioned quality indicators, and we know, there's a lot of problems with high quality indicators because they do measure only the absence of bad things. They don't measure the presence of good things. So it sounds to me like you want to move beyond the minimum to be able to actually measure some of those good things. Can you talk about how we could do that?
Well, some provinces, Mary, do you want to talk about the quality model, the model? Do you want to talk about that, Mary?
Sure, yeah, and Susan, I think you're right. The Health Quality Ontario has some indicators they post as well, and you can go into the website as you're as the public, you can check sort of the trends in long-term care and look at the performance. They call it performance measures. So falls is part of that. The use of psychotropic medications is part of that. So they have a few different indicators. But again, it is what you say, that it provides sort of this, snapshot trending of when things go bad, but they don't give an overall sort of comprehensive assessment of what the homes look like by home, like individual home. I mean, if you had a child and you were sending them to a daycare center, you would want to know, what are there issues in that daycare center? Why is it any different when we look at long-term care? These residents have to make, and families and loved ones and substitute decision makers all need to make informed decisions. But yet, where's the information coming from? Aside from being told, maybe directly by their case manager, oh, this home's pretty good, or this looks good, or it's close by. People are making decisions, only on geographic proximity. That is important, certainly, because you don't want to move away from family members. But at the same time, I would want to know what about these homes? We need more information that presents to the public issues that have been identified, how they look compared to other homes, how they look compared to some standards nationally, provincially, benchmarking. And there are lots of ways that can be done. And so we're proposing that, maybe one way is through this public directory based out of either, some information coming out of inspection reports or some of the quality indicators. You could include a variety of sources of information there that would be extremely helpful for the public. And not to take up too much time, but I think then the other piece of that would be what we want to do is continue on with these exemplars. And I think from that data, you can extract, these are the good things. These are the things we want to be looking for. So not only just what are the bad things that they're doing, but what are those good things, and what's important to you as a resident, as a loved one, that would support your well-being when you enter into one of the homes.
Thanks so much, Mary. I'm going to hand it over to Raisa, but I'm also going to say that people are asking if you are able to tell them who the exemplar homes are. And
No.
so, it's quite typically researchers can't do that.
Yeah.
In fact, collect data with the explicit understanding that they will keep those anonymous. But I just want to get that clear before we moved on to Raisa.
Yeah, another thing which makes it more complex is that this is not a homogeneous population. So if you look at who's going to end up in LTC, it also depends on things like your availability of social and family support and the availability of home care. And then there's also issues around the cultural links, which is certain cultural communities. It's important, what the diet's going to be. And so if you have an LTC home, which is heavily linked in to a particular social community, they may have a community supports, which you wouldn't see in ones that were dealing with people who didn't have the other supports. So that's why looking at the good things becomes trickier, because we're not talking about homogeneous populations.
Yeah, and particularly, I mean, I think the latest figure for Ontario is 10% of people under 65, right, living in long-term care homes. So there's culture, language, age, lots of things, condition, and so we have questions about
that number. Doesn't sound right. It may be 10% of the people in LTC are under that age.
Yes.
Okay.
Yes. Sorry. We have a question about how you consider funding and the incentives and disincentives around maintaining residents as independent. I'm not sure how that would be taken up in your research, but I thought it was an interesting comment. More specifically though, how did you look or include funding mechanisms in your understanding of accountability? And did that have was that a factor in any of your research?
There was one paper written, Blair Robin wrote a paper on the funding mechanisms, and it's published. It's, I think, in another journal. We can send that citation, but he reviews the different funding mechanisms and the private and public. And as you know, the private sector is the most predominant right now in Ontario. And they are subsidized. Well, it depends on what word. Subsidized is maybe not the right word to use, but they do receive provincial funding. So it's a mixed method. And Raisa, do you want to discuss the funding mechanism?
Well, I think one of the things that is tricky is that there is zero requirement that government pay any of the costs except for physician visits of people who are in long-term care, so that you can get into what governments decide they're going to subsidize and what sorts of funding mechanisms they're going to put in place. And one of the classic problems that you run into is that if you're talking for-profit home, where are they going to make their profits from? So, are they going to cut corners in terms of the staffing? Are they going to try to be careful not to take very high needs populations? So it starts becoming tricky, but the literature on for-profits tends to indicate that they tend to cut corners in ways to make their bottom line look better, which can end up being not so good for the people living there. But and somebody, I noticed in the question, asked about retirement homes. And again, that's tricky, because if retirement homes are just a place where you're living, that's like an apartment. But, how much do you get into the sorts of services that count as medically necessary care? And one of the things that makes long-term care trickier is that in a lot of cases, you don't end up in there until you've got so many mental problems that you simply can't function on your own anymore. Because I know somebody who talked about one particular long-term care home, and he said it was basically, he considered it to be the waiting room for a local funeral parlor.
Mm-hmm.
So when we're thinking about the national standards and how they might support an improvement if they were incorporated into provincial legislation as you propose, Are you also seeing in we've seen a draft report of those national standards, we've seen some of that stuff come through. Are you seeing a resonance between those standards and your research that's making you feel encouraged that those will help us move beyond the minimum?
I think it's more comprehensive versus, for example, increasing staffing. What does that really mean? We have a sector that people don't want to go to work. We know that in our other research, right? So, you have to deal with working conditions. And what are working conditions? Working conditions in healthcare are care of people. And if you're going to work in some place where you don't feel you can give adequate care and it discourages you, you're not going to retain the increased staffing. So it has to be a holistic approach to reform. It's not just, good food. It's the standards, at least with this large committee looking at all aspects of care, cover many aspects. And when you're involved in care, you have to, as a leader, if you're one of the leaders, you have to consider all those standards. And so that's why we're looking at a more comprehensive approach versus, build more beds or increase staff.
Yeah. And you're also into this very interesting ethical problem that you also see with things like childcare and other things like that, which is how much are people entitled to help from society once you get beyond, sort of acute medical conditions that need hospital or physician care. And what about the homeless population? So it's interesting that one of the few populations that we have generally said, yes, we will publicly subsidize are people who need nursing home care. So, it's a very interesting ethical problem that we're running into.
Absolutely. But I'd like to just conclude today by thanking you very much for this wonderful presentation. It's been stimulating. We've had tons of questions that are coming through, many participants and attendees. The webinar is recorded and will be available on the CanCOVID site next week. And thank you so much to our guest speakers and to the participants. We really appreciate this.
Thank you for your facilitation. Nice to meet you, by the way.
Yeah, and thanks for a lovely job.
Yeah, thanks.
And thank you all our lovely audience who we didn't get to meet personally, but thank you for your comments.
Someday, maybe. Someday. Thank you.